My name is Hampton Richards. I'm in private practice OBGYN. We're going to talk about three main medications here. The chapter goes over erectile dysfunction, osteoporosis, and obesity. I want to skip around a little bit and start with osteoporosis, if that's okay, because I feel like this is one of the biggest medical diseases, one of the biggest medication areas that I want you guys to understand. The burden of disease is huge. Osteoporosis, osteopenia, bone loss affects more women than heart attacks, breast cancer, stroke combined. It's incredibly common, and the mortality rate for women or men who break a hip is incredibly high. So it's something that we want to be aggressive about identifying, about treating. We have a lot of different medications at our disposal these days, and yet there's a tendency to ignore this disease and not treat it till it's too late because it's such a silent disease. So in any case, we'll get started. I want to talk a little bit about osteoporosis in general and what it is. We only build bone mass until the age of 30. And after that, for the rest of our lives, we deal with bone maintenance and eventually gradual regression. There's two main components to this bone health. One is the breakdown of bone and then the reformation of healthy bone in its place. And what we want is sort of a baseline stability where everything stays about even. Well, the breakdown happens because of osteoclasts, and the buildup happens because of osteoblasts. And all of the medications that we're going to talk about, with one exception, work by decreasing the activity of the osteoclasts. The osteoblast building activity stays exactly the same. So the net effect is either a stabilization or an increase in bone mass. Less destruction and the same build is going to tip your balance and hopefully build a little bit of bone back. Progressive loss of bone mass causes skeletal fragility, increased risk of fractures, which can be life-threatening. Certainly happens in both sexes, but is much more common in postmenopausal women. In men, male hypogonadism, or decreased testosterone, which is very important for bone health, can be a big factor. In both sexes, smoking and steroid or glucocorticoid use is also a big risk factor. The biggest thing to talk about with any patient, especially all postmenopausal women who become high risk after menopause, is exercise, weight-bearing exercise, as well as calcium and vitamin D. So at our annual exams for everybody, men or women, we want to tell them they want 4 servings of calcium a day. You get 1 serving from your daily vitamin that everybody's supposed to get, and then your 3 other servings you can get through dairy products, or you can take calcium pills. Generally, they carry about 2 of those 4 servings in each pill. Every American has too little vitamin D, so some extra vitamin D, either in a vitamin or combined with calcium, is a good thing. The only way to make vitamin D otherwise is with sunlight, and especially with the risk of skin cancer, it really becomes a balance on how much we tell people to go out and lay in the sun versus just getting some extra vitamin D through their vitamins. Weight-bearing exercise needs to be up on your feet, stressing the bones a little bit so that they can reform and rebuild. So a lot of great things like Tai Chi and yoga and walking with weights, as opposed to sitting stationary and doing stretches or stationary bicycle or things like that. Okay, so straight to our medications. The first category are the bisphosphonates. These drugs for osteoporosis are 4. There's alendronate, ricindronate, abandronate, and zoledronic acid, which goes by the trade name Reclast. There's 4 other bisphosphonates that we use not for osteoporosis, but for 2 other main diseases. Paget's disease of the bone is a disorder that has to do with a rapid and kind of ferocious breakdown of the bone, and then a disorganized recreation of that bone. So you get malformed, deformed, sort of knobbly bone structure, causes a lot of problems. It's certainly rare, but to decrease that initial breakdown, you can imagine by decreasing that osteoclast rate is a great treatment for that, at least to slow it down. The other main reason that we use bisphosphonates with these other 4 medications is hypercalcemia of malignancy, complications due to multiple myeloma, and bone metastases from solid tumors. Those other 4 medicines are atidronate, toludronate, pamidronate, and again, zoledronic acid. The mechanism of action we've touched on decreases osteoclast activation, formation, and function, and it increases osteoclast apoptosis, so their destruction. And all that sort of has the net effect of decreasing the breakdown of bone. Again, the osteoblasts function normally. The net result is increased bone mass or stabilization. In terms of pharmacokinetics, these drugs have very poor oral absorption, and that absorption is further reduced by food. So it's very specific in how these patients have to take the medicine. We want them to take it on an empty stomach, first thing in the morning, with no food or other medication for 30 to 60 minutes after administration. They also need to take it with a full glass of water, because one of the main adverse effects from these medicines is that they're incredibly corrosive. So they can cause esophagitis as well as esophageal ulcers. So in addition to having an empty stomach and waiting 30 to 60 minutes, they need a full glass of water, 6 to 8 ounces, and they have to remain sitting or standing for 30 to 60 minutes as well. So you can't give these medicines to a patient who's bedbound or can't get up and move around. You really need somebody who's able to stay up. In a sitting position's fine, but you got to be careful. You got to talk through this with your patients and make sure they really understand the risks if they take it wrong. The main difference between the 4 medicines is how they're administered and how often. Alidronate is given orally, and it can be given either daily or weekly. Risidronate is also an oral medicine, but can be given daily, weekly, or monthly. And abandronate, another oral medicine, is monthly or IV every 3 months. This is important, especially when we're talking about a medicine that's so specific in how we take it. Your compliance goes way down, below 50 and maybe even down to 30% for patients when you tell them every morning they need an hour, just water, and sitting or standing for that time. If they can do that once a month instead, you're really going to increase compliance and really improve those bone health rates. The last medicine, zoledronic acid, is an IV medicine that's only given once a year. Have to send the patient to an infusion center and takes 30 to 60 minutes, but has this real benefit of once a year dosing. In addition to the adverse effects of esophagitis and esophageal tumors, patients can have musculoskeletal pain as well as abdominal pain. And then the big thing that comes out in the press is something called osteonecrosis of the jaw. Really scared people away from these medicines 5 years or so ago, in a large part because dentists wouldn't do any more oral procedures on patients because of this. It's a disorder that gives some bone fragility as well as exposed bone line below the gums on the inside of the jaw on both sides. We've seen it in patients, especially cancer patients, who are using some of those other 4 bisphosphonate medications for hypercalcemia of malignancy or metastatic solid tumors. They get really high doses of bisphosphonates. So when we use high doses in patients that are sick, we've seen this disease. We've never seen it, to my knowledge, in any patients who are taking this just for osteoporosis. And the rates probably hover around 1 in 10,000 patients. So it's very rare. It probably does exist. But in terms of deciding whether we're going to avoid this very rare side effect or treat with a medicine that could help so many people for such a prevalent disease, our benefit far outweighs our risk in giving this. And it's really probably a point of communication that we need to have with our dentists a little bit better. Second category of medications for osteoporosis are the SERMs, or selective estrogen receptor modulators. Remember, these are medicines that have either agonist or antagonist effects in relation to estrogen, and it's different for each medication, and it's different for each tissue type. So the one which is approved for treatment of osteoporosis is raloxifene, which goes under the trade name of Avista. It has a positive estrogen response in the bone, again decreasing osteoclast bone resorption, and then hopefully increasing bone density. It's also approved for prevention of breast cancer in high-risk women, but has the same negative effects as other estrogens in terms of blood clots, about equal risks as estrogen, hot flashes, leg cramps, but no effect on the endometrium. So remember that other famous SERM, tamoxifen, can cause endometrial cancer, and we don't see that with raloxifene. Other estrogens can be used as well. Remember, we don't want to use estrogens in hormone replacement therapy unless the patient has symptoms. But if you have a patient on estrogens for hot flashes or vaginal atrophy, no matter how low the dose is, they're getting bone protection. Once they stop that, once you're able to wean them off for those reasons, then you really need to be watching their bone structure and thinking about getting them on something like a bisphosphonate. Our third medication is calcitonin. Again, this inhibits osteoclast and bone breakdown. It's a hormone produced by thyroid parafollicular cells, and it's given intranasally. Salmon calcitonin reduces bone resorption and increases bone mass, but has not been proven to prevent fractures. So it's not as commonly used. It's certainly more of an adjuvant or a second or third tier medication in people who are failing some of the other therapies. Probably something done by an endocrinologist or an osteoporosis specialist as opposed to a primary practice physician. And our fourth medication is teriparatide. It's a portion of human parathyroid hormone which is produced via recombinant DNA. It's given with intermittent dosing once daily instead of continuously. And because of that, it's the only medicine that stimulates osteoblasts. So it's the only drug that actively promotes bone formation. All the others inhibit bone resorption or osteoclast activity. The problem with teriparatide is it's associated with the risk of osteosarcoma in rats. It's never been shown in humans, but we limit treatment to 2 years because of that risk.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
Hi, I'm Thomas.
Timmy, can you tell me why bisphosphonate should be taken on an empty stomach with 6 to 8 ounces of water?
To reduce the risk of esophagitis and GI intolerance?
As painful as this is for me to say, that is correct. Paula?
Good for you. Good for you.
Yeah, man. It wasn't working for me, you know? It was alright. It was alright. You got the right answer. It's just... Yeah, I'm gonna have to say no. It's not just having the right answer. That was dreadful. That was a waste of breath, of air. You literally wasted moments of my life. For your sake, I hope you can redeem yourself. What bisphosphonate is given once a year as an intravenous administration? Zoledronic acid, you imbecile. For the treatment of osteoporosis.
I even knew that one, sweetie.
Yes, I'm gonna go ahead and speak for everyone when I say no. A big, fat, bloody no.
I'm gonna say no too, Simon.
I already spoke for everyone.
Hi, it's Dr. Chris Lewis, one of the chief educators here at Doctors in Training. It's time for your quick review number 1. Let's get started. How is osteoporosis diagnosed? So this is a very, very common disorder that we talked about with Dr. Richards. So how do we figure out if someone has osteoporosis? Well, first, you can get some clues just by conventional radiography. Now, most of the time, you're not going to be ordering plain film x-rays to diagnose osteoporosis. But say if you get an x-ray for some other reason, you can see that bone demineralization and get some ideas of, well, gosh, this is more than likely an osteoporosis situation. The definitive way that we will diagnose bone mineral density is with a bone mineral density test or a DEXA scan. We will order these routinely for screening, and we'll talk about why we screen here in a minute. But that's the way you do it, and you'll look at the numbers associated with that DEXA scan and decide whether or not someone fits the criteria for osteoporosis. Now, you still need to rule out any other underlying causes. So if you see some of these indications with either radiology, plain film radiology, or with bone mineral density, you want to look for things like cancer, look for multiple myeloma, look for Cushing's disease. You want to make sure you're not misdiagnosing someone with osteoporosis who actually has something much more serious. Another way of diagnosing osteoporosis is if someone has what we call a fragility fracture. So if someone breaks a hip or if they broke another bone from a relatively low impact trauma. So usually a fall from standing. So if someone falls down and breaks a hip, they pretty much have osteoporosis until you can prove otherwise, because people shouldn't break a bone just by falling from standing. Next question. How is a DEXA scan interpreted according to the World Health Organization? So this is very, very important. It can be a little confusing. So what they give us is a T-score, which is the number we use most often. So what is a T-score? Well, the T-score is a reference number to a bone density of a young adult. So we're not comparing, and most of the time we have older people being screened for this, we're not comparing you so much to what your bone should be at your age. We're comparing your bone density to a normal young person. So the ideal bone density, how bad is it when we check a certain individual. So a T-score of -1 or greater is considered normal. So one standard deviation below that young adult bone density and better is considered normal. Now, a T-score between a -1.0 and -2.5, so they're between 1 and 2.5 standard deviations worse or less than that normal adult bone density, is considered osteopenia. So remember that word, osteopenia. That's different than osteoporosis. So a T-score of less than -2.5 is considered osteoporosis. So it's less than 2.5 standard deviations or below that normal adult female bone density. So it's quite a bit worse than the normal adult person. So remember the numbers, -1.0 or greater is normal. -1.0 to -2.5 is osteopenia. And less than 2.5 is osteoporosis. Moving on. What are the screening guidelines for osteoporosis? So who are we going to look for to have this problem? Now, most of the time we associate this with older females. So other things you need to think about, very thin females, postmenopausal obviously, Caucasian women are at higher risk as well. So what are our guidelines? How are we going to decide who to do the DEXA scan to? Well, first, all women, regardless of anything, greater than 65 years of age needs to be screened. So if you see someone who's over 65, they haven't had a bone density, they need one. Next, all postmenopausal women less than 65 years of age need to be screened if they have an additional risk factor. And what are those risk factors? Let me list them for you. So advancing age, so that doesn't really count in this situation right here. Previous fracture, if they've been on glucocorticoids for an extended period of time. If they had a parental history of hip fracture, so one of their parents has a hip fracture. Low body weight, remember how we talked about thin females tend to get this more often. Current smoking, that's a big one. Excessive alcohol, or rheumatoid arthritis. So postmenopausal woman less than 65 years of age with just one of those risk factors. Now, in general, we don't screen men unless they have one of these risk factors. So, but still, if you have a man, especially an older male who's very, very thin, that might lead you more towards, well, you know, we need to start screening this individual as well. Next question. How much calcium and vitamin D should a postmenopausal woman take daily? So this is an important thing. They're getting better and better at this on an over-the-counter therapy. They put the appropriate amount of calcium and vitamin D into each vitamin, but you still need to give your patients the information about how much they actually need. So they need 1,200 milligrams of calcium, and they need 800 international units of vitamin D. And a lot of times you'll have vitamins that actually in one pill will have that much, or in a combination of 2 pills. They can take that much daily. Next, how do bisphosphonates work in the treatment of Paget's disease? So remember how Paget's disease is this overactivity of osteoclasts, so they're chewing up the bone, but then there's this disorganized osteoblastic work where it's kind of disorganized rebone growth. So the bisphosphonates, what do they work on? They're going to work on osteoclasts. So bisphosphonates will decrease osteoclast activity, thereby decreasing this bone breakdown and just sort of the overall process. If you're not breaking down the bone, you're not rebuilding it in a disorganized manner. Next question. Before starting a patient on bisphosphonates, what special instructions must be given to the patient about how to take this medication? Very, very important. I think this gets neglected sometimes and it can get your patient into trouble. So, take it in the morning, about 30 minutes to an hour before eating. This can be hard for some people because sometimes people wake up, the very first thing they do is they go in and drink coffee and eat a piece of toast. So you need to tell them, you need to wake up and only take your pill for at least 30 minutes, an hour is even better. You need to take the medication with a big glass of water, so 6 to 8 ounces of plain water. You must sit or stand for 30 to 60 minutes after taking the medication. So you can't take your pill and go back to bed because that can be a big, big problem. So the next question, why do we ask patients to remain upright by either sitting or standing for 30 to 60 minutes after taking bisphosphonates? Well, this is to minimize the risk of esophageal irritation. And it can get very severe. You can get ulcerations. You also have to be careful if patients have GERD, so if they have gastroesophageal reflux disease, potentially they won't be able to take bisphosphonates. They'll get a lot of upper GI symptoms and they won't tolerate the medication. Next question. List the adverse effects of bisphosphonates. So we talked about this in the last question, at least to some extent. But you can also get diarrhea, abdominal pain, and if you get a lot of abdominal pain, you have to worry about ulceration or gastritis or esophagitis. Musculoskeletal pain. You can get, as we said before, esophagitis or esophageal ulcers. And then you can also get, very rarely, osteonecrosis of the jaw. So be aware of those. Next, tamoxifen increases the risk of what type of cancer? So this will increase endometrial cancer. Now this is not true of raloxifene, so remember that tamoxifen is different. Next question. What is the only drug that actively promotes bone formation by stimulating osteoblasts? So the mechanism by which a lot of these other medications have been working for us is that it's decreasing osteoclasts. But the one medication that actually stimulates osteoblasts, so that's forming bone, is teriparatide. So teriparatide will actually help in the actual building up of bone. All right, so that's going to conclude our quick review number 1. Let's get back to Dr. Richards.
Okay, our second section is on drugs that treat obesity. Obviously another incredibly prevalent disease. More than half of all Americans are overweight or obese, and those numbers are just going up. We do have a couple of medicines that we can use to help patients out with, but primarily we have to remember that this is a disease that's treated by lifestyle changes more than anything else. And these medicines that we use are really more supportive agents for those lifestyle changes, as opposed to magic bullets, which are just going to make the weight gain reverse on their own. So at its core, weight breaks down to calories in versus calories out. And it's really just as simple as that. None of the fad diets or when you eat change that at all. And some of our ancillary things like lap banding or gastric bypass help that by constricting the stomach, limiting the amount that a patient can take in, or decreasing the amount of gut that can absorb the fat and nutrient and carbohydrate, so more of it flushes back out. So again, we're always back to calories in versus calories out. You always want to talk with your patients about their diet at their annual exams. You want to make sure they're getting at least 3 meals a day. You want to look at what they're eating and where their wasted calories are. Food charts can help, meeting with nutritionists. Certainly some of the supportive groups like Jenny Craig or Weight Watchers can be very good because they give a bit of a support group and help structuring diets than just working on their own. And then helping patients make sure that they're getting 5 days a week of exercise, 30 minutes a day, heart rate above 100 to keep that metabolism up. But if all that's failing, especially if you get the sense it's the kind of patient that needs a kickstart, that needs a couple months of medicine that's going to ramp them up, show them that they can lose weight, give them some positive feedback, and encourage them to do the rest on their own, these can be helpful. You just want to be careful because these are high-risk patients from the start, and some of these medicines have some pretty severe consequences in terms of heart attacks and strokes and things like that. So the first category of drugs are appetite suppressants. There's two big groups in this category. The first one is amphetamines. These work by decreasing hunger and promoting early satiety so the patients don't have as much craving and potentially have less calories in. You really only want to use these for a short time only. There's only two that are approved on the market right now. There's been a number of other ones in the past that have been involved in a lot of deaths, heart attacks, cardiac disease, and then after being taken off the market, a lot of lawsuits. So a lot of the commercials you see from lawyers at 3 in the morning focus exactly on medicines like these. So it always makes me a little bit nervous when I prescribe them to patients or talk about them, and we spend a lot of time on the risks. The two drugs are phentermine and diethylpropion. They both work by increasing the norepinephrine release, and that suppresses appetite. Other amphetamines in the past have increased dopamine as well, but again, those are off the market at this point. Adverse effects are basically kind of ramped up amphetamine stuff like you would expect. Insomnia, euphoria, irritability, nervousness, dry mouth, but mostly hypertension from a medical standpoint you'll see, and then the big risk is cardiac disease or heart attacks or stroke. The second drug in the category of appetite suppressants is sibutramine. It not only increases norepinephrine, but also serotonin. So it's a serotonin norepinephrine reuptake inhibitor. You can use it for up to 2 years, but no more than that. Mechanism of action is increased norepinephrine suppressing appetite. The adverse effects are similar: dry mouth, nausea, hypertension, and maybe a risk of myocardial infarction or stroke. And I'll tell you, I actually get back to that couple of months thing as opposed to a couple of years, just because it does make me nervous. Okay, our second big category is orlistat. This is an entirely different type of medicine, again, decreasing calories in, but by a different mechanism. This works by inhibiting gastric and pancreatic lipases, which reduce the absorption of dietary fats by up to 30%. So lower caloric absorption equals more weight loss. The problem is that it can cause a bunch of side effects too, especially when the patient's first starting. The big things that we read about in terms of adverse effects are always a little unpleasant. So we talk about oily rectal discharge and flatulence and fecal urgency and increased defecation. And usually just by talking about this with patients, you kind of make them not want to take the medicine anyway. It is a good medicine. And only about 15 to 30% of patients who take it get these problems. And then they reduce it even lower because they learn really quickly that if they reduce the fat in their body, there's going to be less fat not being absorbed and then coming through their system to give them all these problems in the first place. So part of the way the medicine works is by decreasing the absorption of fat, and part of it is a learned behavior. Patient learns that they're going to have all of these unpleasant side effects if they eat a lot of fatty food, so they start eating a little bit healthier. You take it 3 times a day. You have to take it with your meals. And the other big side effect is malabsorption of fat-soluble vitamins. So you got to think what those are: A, D, E, K, and beta-carotene. We have these patients take an additional vitamin supplement, but not at the same time because they won't absorb it. So about 2 hours apart from taking the orlistat. And that sort of covers that medication. You'd think that there would be a benefit of taking both of these together, but there's not in any of the studies. So really, you want to work on diet and exercise. If you need to pick a medicine, think about if you're trying to give them a jump start, a couple months of ramping them up and showing them they can lose some weight, but for a short period of time and only if they're safe from a cardiac standpoint. Or do you want to give them something that's going to give them a little bit more of a learned behavior response, which is the orlistat, help them retrain their diet to avoid side effects, and also something that you can use for a much longer period of time. Okay, the last category on here is listed as the first one in your chapter, but drugs to treat erectile dysfunction. This is probably hard for you guys to imagine, but, or at least most of you, but about 10, 15 years ago, this wasn't out there at all. And then there was this huge ad push, and they got a spokesman who was a presidential candidate to come talk about erectile dysfunction and how much these medicines like Viagra had helped him. And all of a sudden, because it was every other commercial on television, people really started talking about it. And all of a sudden, it's really out there. And men have very little embarrassment, at least in their doctor's office, about bringing this up. Whereas you can imagine back in the 50s, this never came up because it was certainly seen as a less than masculine problem to have. But it's very common. Over 30 million men in the United States have a problem with erectile dysfunction, and it's especially prevalent among men with vascular disease, hypertension, and diabetes. And it might be easiest to think of this as a vascular disease. As men get older, and women, their vessels become less pliable, they become more rigid, they don't relax as easily. And that's really the essence of how these medicines work as well. So all the same problems or all the same medical complications that give people problems with cardiac disease and hypertension give problems with this as well. Before we came up with these medicines, the treatments that we had were a little cumbersome. A lot of these treatments are still out there and are reserved for patients who fail these medications. They do work very well, and men who need them are glad to have them, but they generally involve uncomfortable urethral suppositories or some sort of penile injections or implants. Today, I think the most common thing is a pump, which is actually pretty discreet, more so than you would think. But still, at the same time, if you could take a pill instead of having an implanted pump, I think almost all men would favor that. So we're lucky to have these. There's only one drug category here. It's the phosphodiesterase 5 inhibitors, or PDE5 inhibitors. There's three main drugs that work similarly but have different onset and duration of activity. Those drugs are sildenafil, vardenafil, and tadalafil. So all of these have the suffix "fil," which I'm sure you guys realize is an easy way to remember them and no mistake by their marketing companies. When you think about the mechanism of penile erection, sexual stimulation leads to nitric oxide production. This activates guanylyl cyclase, which creates cyclic GMP. Cyclic GMP causes relaxation of smooth muscle in the corpus cavernosum, or vascular wall relaxation. So the corpus cavernosum fills with blood and the penis becomes erect. So the issue here is a relaxation problem for a big vein. It's really the easiest way to think about it. So with a PDE5 inhibitor, PDE5 is what degrades cyclic GMP in the corpus cavernosum. So if we inhibit that action, cGMP is going to stick around longer, the amount of blood flow is going to increase, and the patient's going to have an improved erection. It's important to remember that PDE5 inhibitors are not aphrodisiacs, so they don't cause erections to happen. They only allow that vascular relaxation with sexual stimulation or arousal of some other sort, which is a good thing. It doesn't mean you'll have an erection for 4 hours, but it does allow one in the right situations. So pharmacokinetics, you've got to explain to the patients how far ahead of time they need to take it and how long it's going to work for. And again, that's the big difference between these three medicines. The first two, sildenafil and vardenafil, the onset of action is about an hour ahead of time, and its absorption is decreased by food. The opportunity for erection only lasts about 4 hours after administration. So it's a relatively narrow window. Tadalafil is a lot more convenient for the patient. They have to take it a full 2 hours ahead of time, but it lasts 36 hours. So the patient doesn't have to do as much planning, doesn't worry about having to go out for a steak dinner with their wife ahead of time or anything like that. So obviously it's a more expensive medication, but it gives a lot more opportunity and is a lot better for convenience of the patient. Adverse effects also have to do with vasodilatation. Patients can get headache by dilatation of the vessels in the brain. They can get flushing in the face. nasal congestion, orthostatic hypotension, so when you go from laying to sitting to standing, your vessels need to squeeze to push that blood back up to your brain. If they're relaxed because of a medication, you can get lightheaded or even loss of consciousness. And then sildenafil is unique, Viagra is unique in that it causes disturbances in the blue-green color discrimination by PDE6, not PDE5, but PDE6 inhibition in the retina. The other drugs don't cause this. And the other thing to remember is that all three are metabolized by cytochrome P450. So we'll just remind you guys of the drug list of medications and food groups that either ramp up or slow down the cytokine P450 system. This is something that's going to come up again and again and again. So another great slide to pause, memorize. You're going to need to do this a bunch of times, but you're going to need it for the rest of medical school and residency. Other risks with these medications, there's some degree of cardiac risk, but only because of sexual activity, not because of the medication itself. So PDE5 inhibitors will not cause your patient to have a heart attack. But if your patient gets very active for the first time in years, that can give them a heart attack. And your medicine might encourage them to do so. So talk about that risk for the patients. Very few men are going to say no because of that, but you at least want to make them aware. And then drug interactions. This is the other big thing to remember. Nitrates are always contraindicated for patients on PDE5 inhibitors. That's because PDE5 potentiates the effect of nitric oxide. So the patients who have these pills for angina need to know that they cannot take them while they're on this medicine. And maybe a shorter acting medicine is a better choice for those patients. Another group is alpha adrenergic antagonists or alpha blockers. Gives an additive hypotensive effect and can drop blood pressure. You have to use these PDE5 inhibitors with caution in these patients. And then finally, once again, reviewing that chart, thinking about your cytochrome P450 and the different medicines that are going to increase or decrease the activity, especially ones that increase the activity of PDE5 inhibitors. Ones that decrease that CYP3A4 are going to make that PDE5 inhibitor stick around a lot longer, so we just want to start with a reduced dose.
Now let's pause for a moment and review the material that was just covered. Before we do that, if you haven't already done so, this might be a good time to read your pharmacology text that corresponds to the material that was just discussed. Then together, we'll go through the quick review in the study guide.
We never thought it would happen
To me.
to us. Then one day it just happened.
It was really embarrassing. I just didn't know what to do.
Then we found out about this new product.
It sounded really promising, so I decided to give it a shot.
It certainly worked. I started recommending it to all my friends.
She certainly did.
It really saved our sex
Marriage.
life.
Patients taking nitrates for heart disease must not use Erectia, as the combination could result in life-threatening hypotension. Side effects may include headache, nausea, facial flushing, erection, upset stomach, and sensitivity to light. In the rare event of an erection lasting more than 10 hours, please call your wife and clear your schedule.
All right, it's time for your quick review number 2. Let's get going. What are the 2 classes of appetite suppressants and the medications in each class? So you're going to run into a lot of people in your clinic who want to get skinny, though they don't really want to do anything for it. So you need to know about your medications, know who you can use them in, because it can be a big, big deal. So amphetamines is the first classification, and that's going to include phentermine and diethylpropion. So those 2 medications are most commonly used. The next one is a classification, serotonin norepinephrine reuptake inhibitors, and you'll recognize this category. We use this a lot in depression, but sibutramine is the medication that we use for appetite suppression. In 2010, sibutramine was withdrawn from the market in the United States because of the risk of MI and stroke. Next, what is the mechanism of action for phentermine and diethylpropion? So how do these things work? Well, overall, they increase the release of norepinephrine and dopamine from the nerve terminals. And then they subsequently will also inhibit the reuptake of norepinephrine and dopamine. So this increases the overall levels of the neurotransmitters in the brain. So subsequently, you get appetite suppression, so people don't feel as hungry, and therefore they don't eat as much, and hopefully they lose weight. Next, patients who take orlistat can decrease their fat absorption by what percentage? So orlistat blocks some of the fat absorption. You get the really nasty diarrhea. It's really fatty and foul smelling, so people learn not to eat a lot of fat. But the fat they do take in, it can block about 30% of that absorption, so it can be very helpful. Next, what are some contraindications for orlistat? Well, you want to avoid it in patients with any type of chronic malabsorption syndrome, and then patients with cholestasis. So you don't want a bunch of bile hanging out that can't flow from the liver to the duodenum. Next, what are some physical and psychological causes of erectile dysfunction? Again, as Dr. Richards mentioned, very, very common. You'll have lots of men. The way I find that it happens most often is you talk about all the other problems, and then at the very end of the visit, my wife wanted me to ask you a question. And then you go into that. And it usually goes pretty well. There's still a little bit of worry or embarrassment on the part of the male patient who comes in with this problem. So vascular disease is a big one. Diabetes, and that kind of goes along with that microvascular disease. There are medications that can cause this, especially beta blockers can be a big deal. Depression, that can be huge. You know, people come in and tell me, well, I just don't really want to have sex anymore, though my partner really wants to have sex. I just don't feel right. And then you can kind of go down the pathway of like, well, maybe this isn't, just about sexual intercourse. This has more to do with just an overall or undiagnosed depressive state. And then another one is sequela to prostate surgery. So that can be a big one. So if they had prostate cancer, if they had a radical prostatectomy, that could certainly knock out erections. So be aware of that as well. Next, what is the mechanism of action for the PDE5 inhibitors? So they inhibit the isoenzyme PDE5, which is responsible for the degradation of cyclic GMP in the corpus cavernosum. So that corpus cavernosum will relax, so then you get increased blood flow into the corpus cavernosum when sexually stimulated, and therefore you get an erection. Next question. Sildenafil can cause disturbances in color vision. What color will you see with this? Well, you get this sort of blue-green discrimination problem. So blue-green, one way to remember this is that, I don't know how often they've advertised this recently, but they used to call sildenafil or Viagra the little blue pill. So if you can remember the little blue pill can cause blue-green vision problems, that's a good way to remember it. Next question. List the cytochrome P450 inducers and inhibitors, which can be remembered by the mnemonic BCG, PQRS, and pick eggs. So you'll run across these questions pretty commonly. And luckily there's some nice lists here. They're not complete, but if you can remember these are the big ones that if you have board exams or pharm exams, if you can remember these, I think you'll do okay. So first are the P450 inducers. So BCG, PQRS, and that's going to stand for barbiturates, carbamazepine, griseofulvin, phenytoin, quinidine, rifampin, and St. John's wort. Now, for the cytochrome P450 inhibitors, think of pick egg. So protease inhibitors, isoniazid, cimetidine, ketoconazole, erythromycin, grapefruit juice, and sulfonamides. So be aware of those when you're using your erectile dysfunction drugs because that can change the effectiveness of those drugs. Next, a 65-year-old male presents to the ER with chest pain that radiates down the left side of his neck and down his left arm. You suspect he is having an MI or myocardial infarction. Besides giving the patient oxygen and morphine for pain, you would like to give him nitroglycerin. What important question must you ask this patient before administering nitroglycerin? This is great. You will get dinged on this because you don't necessarily assume everyone's taking erectile dysfunction medication. So they're coming in for a heart attack. You give them nitroglycerin and all of a sudden, poof, their blood pressure goes down to nothing and they're going into shock. And you go, oops. So always know if someone's taking erectile dysfunction medication. It's more and more prevalent out there because you don't want to combine it with your nitroglycerin because you can cause life-threatening conditions. All right, so that's going to conclude this quick review number 2. It's next going to be time for our end of session quiz. So I want you to stop the video. I want you to answer all the questions of the end session quiz and then restart the video and we'll go over the answers together. All right, it's time for your end of session quiz. Let's get started. What is the mechanism of penile erection? So we've got our progression here. First, it starts with stimulation. Then you get production of nitric oxide. You get activity of the guanylyl cyclase. You get increase of cyclic GMP. You get relaxation of smooth muscle of the corpus cavernosum. You get increased blood flow, and voila, you get an erection. Next, aside from medical treatment, name the strategies to reduce bone loss in postmenopausal women. So we talked about bisphosphonates and all the drugs that can help us with our osteoporosis problems. What can we do on top of that? So first one, weight-bearing exercises. So the more weight you have on your bones, those bones will say, well, we need to hold up a fatter, bigger person. So we're kind of tricking it. So they will increase the bone formation. Adequate calcium and vitamin D intake, and what were those numbers? 1,200 for calcium, 800 for vitamin D on a daily basis. You have to stop smoking. You really have to impress upon your patients, please stop smoking. You're going to break your hip and you won't like that. And then if you can, though it's not always possible, especially with inflammatory diseases, avoid glucocorticoids, especially long term, but this can be very difficult, especially with your patients with, say, rheumatoid arthritis. And if you do have someone on rheumatoid arthritis and they're on these type of medications, make sure you're scanning their bones because they might have horrible osteoporosis and you're not going to know until you check that DEXA scan. Next, how does phentermine and diethylpropion work to encourage weight loss? Well, we've talked about this before. They increase norepinephrine and dopamine, and they also decrease the reuptake of those neurotransmitters as well, and then they subsequently will suppress the appetite. So what type of adverse effects will you get as a result of that increased norepinephrine? So it can cause a lot of the amphetamine-like reactions. So insomnia, euphoria, irritability, nervousness, dry mouth. Very importantly that you need to check, especially in subsequent visits, blood pressures. You can have hypertension, cardiac disease, and stroke. So these are not benign medications. They can be a big deal, so be aware of, especially of your patients who are maybe borderline hypertensive patients. Next, on a bone density DEXA scan, what are the T-scores for normal, osteopenia, and osteoporosis? Well, we went over this before. Remember, negative 1.0 or higher is normal. Negative 1.0 to negative 2.5 is osteopenia, and less than negative 2.5 is considered osteoporosis. And just another part of the information here, where are we scanning people on these DEXA scans? What bones are we looking at? Well, we're mostly looking at the spine and we're looking at the hip. And those are very important places because that's where we're going to have major pathologic fractures with major mortality and morbidity. Next, match the drug with the correct mechanism of action. So toludronate is going to go right across here with decreased osteoclastic activity. Sildenafil will inhibit isoenzyme that degrades cyclic GMP. Raloxifene is an estrogen receptor modulator. And then orlistat will inhibit gastric and pancreatic lipases. Next question. Describe the mechanism of action of bisphosphonates. Well, they're going to decrease osteoclastic activity, and this will decrease the bone degradation. And then it will increase osteoclastic apoptosis, so it gives you this programmed cell death. So overall, we're decreasing osteoclastic activity. Next, which PDE5 inhibitor has the longest half-life, and why is this distinction clinically important? Well, tadalafil has, in some patients, an 18-hour duration, maybe a 24-hour, maybe even up to 36-hour duration. And it also takes a little bit more time to get started. So sometimes it takes 2 to 3 hours to actually get to where it's working, but it is going to last a long time. And this can be very nice for patients. They can take their medication early in the evening and then not have to worry about timing of sexual activity later on in the day. I've even had patients get 2 days worth of sexual activity out of a pill, and even one time I had a patient say they got 3 days out of one pill. So hard to know exactly how long that's going to work for a patient, but it is a lot longer than our other two types of medications. Next, what two medications are contraindicated in patients taking PDE5 inhibitors? Well, we talked about nitrates. Remember, we talked about our nitroglycerin situation with an MI. The other medication you need to remember, alpha blockers. Now, alpha blockers are going to block your alpha-1 peripheral vasoconstriction, so you can dangerously decrease that blood pressure and get orthostatic hypotension. Next question. What is the osteoporosis treatment that promotes osteoblastic activity? Recall how we talked about most of our medications are working on osteoclasts. The one that works on osteoblasts is teriparatide. And finally, what benefit does calcitonin provide to patients who have an osteoporosis-induced vertebral fracture? So if you can imagine someone who has a fracture, it's very, very painful. But when you give calcitonin, you actually can get some pain relief. So calcitonin improves pain in those vertebral fractures. All right, so that's going to conclude our end of session quiz, and that's going to end our lecture for today. I hope you learned a little something, and good luck studying.